Hi, everybody. This is Libby Sagara with Blue Path Health. We're getting started in just a minute here. I see a lot of people logging on, so I'll give a moment as people get dialed in and on the Zoom. As you'll all notice, you're all on mute. We usually have a good number of people on these calls. For those of you who are new to the eConsult work group, we meet on a monthly basis to share webinars and great presentations on eConsult best practices in provider engagement and adoption and sustainability. So we'll get started with our wonderful speakers for the day in just a moment here. Just wanted to point out, you can unmute yourself if you wish to point out something, but I would prefer that you use the group chat feature if you'd like to share a question. And I think it's pretty self-explanatory since I'm sure you've all been doing a lot of Zoom lately. So I won't give you any tutorial on that. So once again, thank you for those of you who are new to our group. The eConsult work group has been around for about 5 years now, and we're glad to see our membership growing. We started out as a fairly California-focused group, and we're expanding nationally, and we have some great participants internationally also. So we're glad to see some new faces today. So I'll move ahead to our agenda here. It's a full agenda. We have some wonderful speakers, experts from the academic medical center setting. We have Dr. Shalina Nair and Magana from the Ohio State University College of Medicine. And we also have Dr. Alpesh Amin from University of Irvine. So without further ado, I'm going to get started and hand off to Dr. Nair and Magana. Dr. Nair, I'm going to ask you to take yourself off mute so we can get started. And Candy, I'll hand off to you.
Great. So thank you so much, Libby. Our presentation is entitled Leveraging the Clinical Transformation and Technology Framework to Expand Telehealth in an Academic Medical Center. Next slide, please. And just again, welcome. Thank you so much for joining today. Next slide. So today's presenters, myself, my name is Candy Magana. I'm the director for the Center for Primary Care Innovation and Transformation, housed within the Department of Family and Community Medicine at the Ohio State University College of Medicine. I've been my career has been steeped in quality improvement, health innovation, practice transformation, and quality and working in primary care to serve the underserved. Some of my positions that I've had in the past have included organizations such as Blue Shield of California, Rubicon MD, UCSF Center for Excellence in Primary Care, as well as New York's Primary Care Association. Dr. Nair, would you like to introduce yourself?
Hi, Shalina Nair. I'm the Vice Chair of Quality and Innovation for the Department of Family and Community Medicine, and also the clinical lead for the eConsults program.
Thank you. Next slide, please. So today we have two major objectives. The first is that we want you to come away with an understanding of the clinical transformation and technology framework and explain how CTT can potentially help you as a telehealth leader. The second is that we wanted to actually contextualize this information for you. So we're going to be doing this in two ways. The first is how OSU and specifically the Department of Family and Community Medicine use this framework during the rapid adoption of telehealth modalities during COVID-19. And the second being how OSU's overall eConsult program aligns with the framework. Next slide, please. Thank you. What I'd like to do now is facilitate some level setting about what the framework is and the context in which the framework was created. Next slide. So I wanted to acknowledge that as is, there are some major barriers for healthcare leaders such as yourself as it relates to telehealth implementation. And generally we could say that these barriers fall into four major categories. The first can be financial. Many telehealth innovations are not currently reimbursed by payers. And then the major barrier becomes, how can we actually afford to use this technology if no one will pay for it? The second is structural. Sometimes the tech and your systems may not be aligned, or there are other needs such as integrations that will take time to work through, which can delay an implementation. The third is operational. So healthcare leaders implementing technologies may need to decide on how the technology will be used or who will get to use the technology first. And the fourth challenge is challenges in regard to human resources. So do we have the people and power in terms of staffing and expertise to make an implementation successful? Next slide, please. And then on top of all of the different current challenges that we are facing, the unprecedented COVID-19 pandemic hits, and then everything literally turned upside down for us. So implementations not only need to happen faster with little to no lead time, but we also have to do this in a socially distanced and virtual manner. So needless to say that an already challenging situation is made that much more difficult. Next slide, please. And within the context of implementation, there are different stages of adoption that telehealth leaders will encounter. So adoption and selection, implementation, and expansion and integration. For the sake of time, I'm not going to go into all of the details listed in this slide, but I did want to point out that an organization can simultaneously be in multiple stages of implementation, which makes things a little bit more hairy to work around. And one example of this would be being an organization expanding a platform across their network while also piloting an integration within an EMR. Next slide, please. So as Libby had mentioned, or as I had introduced myself, I had served as the manager of clinical transformation at Rubicon MD alongside Dr. Wanda Olayiwola, who many of you know, who at that time was Rubicon MD's chief clinical transformation officer. And during this time, Dr. Olayiwola observed that if we were to apply concepts that we already use in healthcare settings, things like implementation science, translational science, and quality improvement principles, we would actually be able to prepare the people and places for technology implementation with minimal disruption while also having an optimal experience. Next slide, please. And what we found through our direct experience implementing e-consults is that what we needed to do was actually pair practice facilitation with the technology implementation. And as we continue to have success at Rubicon MD using these principles, we then translated our processes into the clinical transformation and technology framework. Next slide. And there are three major reasons why we actually decided to formalize this framework in the first place. The first is that because of the complexity of healthcare systems, telehealth initiatives fail or cannot scale. The second is that these technology implementation skills are often not taught in the training of most healthcare professionals training. And these are often the people that are at the helm of leading the technology initiatives at the end of the day. And then the third is that digital health requires new and creative approaches. Next slide, please. So here's a clinical transformation technology framework, and it consists of the 5 L's, each of which are phases that can be used in the implementation of a new technology or revisited for a technology that has already been implemented. And these L's include logistics, landscaping, looping, launching, and leveraging. Next slide, please. So many of you have perhaps seen this publication documenting OSU's telehealth adoption journey. And this is going to be the first example where we actually contextualize the CTT framework within the Department of Family and Community Medicine. So we're a department that already we're using telehealth modalities and also newly adopting telehealth modalities during the pandemic of COVID-19. Next slide. So if we're talking about logistics, this is the first phase where you legally and technically prepare the clinical environment for the adoption, implementation, or expansion of technology. And this includes basic things like executing contracts and sharing data agreements. In the case of OSU, the medical center actually made the decision to have all departments have the option of continuing the IHIS platform in addition to adopting a third-party platform. And some of the steps that we were taking during the logistics phase were obtaining department representation in the larger medical center work group, providing feedback on the exploration and vetting of the proposed platforms. So this included, does our system have the capacity to actually support this new technology in addition to the technology that we're already using? Is there EMR integration potential? And then most importantly here, because of video visits, was there a compatibility for iOS and Android platforms for providers to use both? And then we also wanted to contribute to the software deployment strategy of both hardware and software across all of our department sites. Next slide, please. So in terms of landscaping is a CTT phase where you gain a deeper understanding and knowledge about the current clinical environment and state of affairs, including how the technology will actually address or impact the current workflows and address gaps. And this is especially important for external partners collaborating and engaging in clinical environments that they'll be working in. at OSU, we had to do quite a bit of pre-work before any type of go live. Once we understood the technology and the options that would be available to clinicians across the medical center, what we did as a department was we revised the schedule templates and visit type architecture. We re-engineered processes and workflows. So this included what we were going to do virtually for patients and what we were going to do for the patients that were actually coming physically into the offices. What would we do for the patient check-in and check-out procedures? What new billing protocols would we have to implement? And then in terms of smart phrases, how would we, what smart phrases would we be creating to help physicians make this an easier process for them? We also created SMART goals and established timelines. And then we also made sure that there was alignment on patient communication and messaging across the medical center. Next slide, please. Thank you. Looping is where we take all of these findings, learning, and feedback from the logistics and landscaping phases to create the foundation of a customized training plan. And in our department's case, in order for us to create this plan for rollout, we needed to do a little bit more work. So what we did was we identified a physician super user. We tested each of the platforms by location and modalities. And then we provided any critical feedback to the larger medical center telehealth work group. And in addition to that, we created a remote virtual best practices checklist. So all of these different components were going to be helping us for the launch and the go live. Next slide, please. So launching is a phase of is a phase where we actually kick off the initiative with end users and anyone else that will be impacted by the technology. Launching is typically associated with the training efforts to engage the end users in a dynamic way. And this is often where I think partners often focus on simply the training. In the case of our department training efforts, those were already underway. So we decided to pivot, and that meant for us, our department hosting department work group office hours so that we can troubleshoot issues in real time for those that needed refreshers. We also did refreshers on the actual tip sheets themselves. So we were able to actually identify where those were, easily provide links, and also highlight the most important information. And then we accommodated for telehealth visit modality preferences during patient scheduling, and we created and also held campaigns about our virtual rooming workflows. Next slide, please. Thank you. Leveraging is the phase where you take all of the information and learnings from the launch to better understand the impact of technology on the clinical environment and the end users. And this is the phase that I would say is actually the most important. In our department's case, our telehealth work group continued to meet on a weekly basis. We created a dashboard that aligned with the defined goals we had agreed upon in the landscaping phase of the framework. And then based on what data was coming through, we would then provide weekly data updates to the department and clinical leadership to see where we were wavering, where we were doing well, and then how we could improve. And then we took all of this feedback to problem solve and troubleshoot. And we got this feedback from various resources and various end users. So in addition to the providers, we also asked care team members, patients, and interpreters what they thought of the process and how that was impacting them. Next slide, please. Thank you. And at the end of this product phase and the implementation of this framework, we were actually able to see the sustainment of the use of telehealth modalities, where if you can see here on the graph, pre-COVID, we were actually in the piloting phase with varying degrees of success, and I would actually say minimal success here. What the CTT framework allowed us to do was actually to create a roadmap in a time where we had to accelerate telehealth adoption at a very rapid pace to keep up with administrative tasks, patients' demand, and a rapidly changing healthcare landscape. And so with this, I'm going to transition the presentation to my colleague, Dr. Shalina Nair. Next slide, Libby. Thank you.
Thanks, Candy. So our eConsult program was already in place, but as I've reflected back, I've seen a lot of alignment between what we did at OSU and the CTT framework that Candy just discussed. And so we want to share how you can use this framework to think about the current state as well as further expand on the program. Next slide. Our program is part of the AAMC's Project Core, which I believe many of you are familiar with, to coordinate optimal referral experiences. They supported our initial adoption in January of 2017 with dermatology, and we can still consult with them and the other AMCs as needed. We currently have 18 specialties live, and our system, our program is internal to OSU. So I'm going to now show how our program aligns with the CTT framework. The first step is logistics, where we prepare our environment for the innovation. Now, our system was already set up with Epic's IHIS platform, so we just needed to make sure that our templates were aligned and integrated with the current functionality. One unique aspect of our program is that we did leverage Lean Six Sigma methodology to establish the voice of the customer, which is mainly the PCP end users, to make sure that our templates were optimized to meet their needs, but also balanced against our IT resource capacities, so that our builds are efficient to promote high user satisfaction and repeat utilization. So there was significant effort up front. Next slide. So our end users are any physician or APP in the medical center. We did not limit just to primary care providers, although they are the highest users. So as mentioned, our platform is internal, and the templates integrate with IHIS. And our specialty network consists of internal specialists. Each department that we do onboard has one specialty champion to help support their participation in the program. Next slide. So next we have the landscaping phase of the CTT framework, where we get a deeper understanding about the current environment and how the new program is going to impact the current workflows. So in the beginning, there were focus groups and stakeholder meetings, but essentially the team was restructured in mid-2018, as often happens with a new program. And that's when we really established the current team and also got a new program manager, which was actually really crucial for the success of our program. Next slide. So we have an executive sponsor who essentially champions the core model and makes sure that it aligns with the institutional goals and mission, and also supports future scale and sustainability of the program. Clinical leads, myself, and I have a counterpart in internal medicine, and we lead program implementation in collaboration with our colleagues across the medical center, and essentially run day-to-day activities regarding implementation, provider engagement, and troubleshooting. We have a specialty champion whose role is to help engage our specialist colleagues as well and help with any questions or concerns they have during implementation or once they go live with the program. And again, a project manager to coordinate all the activities, and IT who completes the template builds and all the technical work. And again, we can consult with the AAMC as needed. So currently we have both Medicare and OSU Health Plan that's reimbursing for e-consults. One of the reasons that we've been able to be successful and sustain the program is that we do have the support of our health plan, who is reimbursing for the services at the same rate as Medicare. This just shows the top 3 placed e-consults in regards to payers. So it is working out with the ones that are reimbursed. Next slide. This is our current workflow. I'm not going to review each step, but you can kind of get an idea of our process. A few key highlights is that we do have an expected response time of 3 business days. And also, if the e-consult is converted, so the specialist thinks that they need to see the patient instead, they can route that to their internal scheduler and then schedule directly off of the e-consult order. So there's no new referral that's needed. So again, we really try to have this be user-friendly on both sides so that it's efficient with limited redundancy. Next, we have the looping phase of the CTT framework, which is where we collate the previous findings and feedback and establish a foundation for the foundation and plan for the program. So here we already defined the champion and lead roles and made sure that we had the key people that were needed to have a successful program, as well as a robust implementation process. Next slide. So we have 4 phases in our implementation process. So first, we have a kickoff meeting where we meet with the specialty to go over the program details, review their referral volumes to help identify conditions that would be appropriate for e-consults, and identify champions for their specialty. Next, they complete a conditions worksheet with the required data that they need for the template builds. Then our IT team builds the mock-up templates that we then review to make sure, again, that they're efficient and user-friendly on both sides. And then last is go live, where we introduce that new specialty, and it's implemented in IHIS, and then we communicate that with our colleagues so that they're aware that we have another specialty on board and available. Next slide. So this just shows our current specialties that we have live. We have more in the works, but we've got 18 live so far across the medical center. We have a few unique specialties, one that's live, which is breastfeeding medicine, and then another in the works, which is transgender medicine. So we're trying to really consider access and equity for our program. Next, we have the launching phase of the CTT framework for program kickoff. And so here we did have a significant educational campaign throughout the department, and that's where we really made sure that the primary care faculty had been trained on proper use of e-consults. We have tip sheets that are created for training purposes, and that's for both sets of users. Next slide. And this just shows just an example of our tip sheet that helps facilitate the process. It's a little small, but I think you can get the idea. And then last, we have the leveraging phase of the framework, where we gain an understanding of the program's performance and user experiences. So we have surveyed family med and general internal medicine faculty and residents, and also specialists, just to get their feedback on the program so far. Faculty and residents actually all felt strongly that the program enhanced their ability to provide care, enhanced their career satisfaction as a primary care physician, and enhanced their communication with their specialty providers. The specialists also felt positively that the program enhanced their ability to provide care and improved communication really with the primary care providers. We also have a data dashboard where we can review the data and do quality assurance, and a steering committee to review the program, which includes billing updates, payer discussions, data, and sustainability. So that way we can address any problems and troubleshoot based on end user feedback. Next slide. So this shows our specialty data for this from January to July of this year. So as you can see, I mean, dermatology is the highest used e-consult. It does lend itself really nicely to e-consults. We also have GI, pharmacy, cardiology, and hematology that are pretty frequently used. Next slide. And then this just shows our data trends. Again, for this year, the thing that we were happy about was that utilization has been really consistent despite COVID-19 and the push for other telehealth modalities. And so it was good to see that there was not a drop off in e-consult utilization during the transformation to telehealth. Next slide. So, I mean, next steps, we're really just going to do a deeper dive into the data and continue to work on improving the quality of the program, considering different SMART goals to ensure accountability and sustainability, and then just get end user feedback to do further educational campaigns as needed. Next slide. And then next slide. This is just a publication that we were involved in. It was published in October of 2019 in the Journal of American Academy of Dermatology, which showed that e-consults helped to improve access to specialty care for underserved populations.
And this is the article in Harvard Health Policy Review where the Clinical Transformation in Technology framework was initially debuted. So feel free to look at that and see how our how our framework actually related to e-consults.
Thank you so much, Candy and Dr. Nair. We have some questions coming in. Before I launch into questions, did you have any statements to wrap up? I think we have a good number of comments coming in. Anything else from you before we transition? Okay, so I'm gonna read these. Please use the chat feature to share additional questions. The first is something that we as a work group have been grappling with, and it's a challenge, I think, to programs across the country, how to communicate to patients in settings where there is patient consent required, or where there may be a copay coming into play for telehealth or e-consult. So the question from Miriam McGuire was for Medicare. Do you obtain patient consent before doing an e-consult? And if so, how do you do that? Dr. Nair.
Yeah, so we do. Our templates, there's a couple of different ways to do it actually, but each e-consult template that we build, so for each specialty, for each condition, the very last statement on it is reviewing that you have reviewed the patient, the possible co-insurance copay costs with the patient. And you actually have to click, like there's a box that says yes. So it's a hard stop. So each patient really is consented prior to placing any e-consult. That said, I do know that earlier this year, they also have kind of the universal broad consent,
Yes.
which in theory, patients with all the telehealth visits, so really any consent is good for the year, but we decided not to remove that from e-consults, from the templates, because we felt that it was still important to make sure that they understood that there were likely to be, co-insurance or copay costs associated.
Thanks, Dr. Nair, and this is super important that this is a topic we'll cover on our November meeting, since there are many questions around consent, but it's good to know that that's being captured for e-consult too.
Yeah.
So we have a few other questions. One thing that stood out to me and also came in through to me, Leslie, was around breastfeeding. I think you had a great list of specialties that you cover through e-consult. Some of these are, more perhaps traditional clinical services, and then others such as breastfeeding are new, and we haven't heard of those types of services delivered via e-consult. Are all of your specialties, or do you consider clinical or non-clinical, or is there any sort of gating factor about which services you provide via e-consult, or is it just anything that could help the patient?
I mean, really anything that can help the patient, to be honest. The breastfeeding medicine was one we just went live with this year, and they actually saw, we try to recruit people and think about things. They actually sought us out because I think there's a couple providers. One is an OB-GYN and one, I believe, is an internal medicine who does a lot of, breastfeeding, gynecology, that kind of care. And so I think they mentioned that they were getting a lot of questions. I think it's a lot of it is about, like, literally just about breastfeeding, like over under production or mastitis, or just any concern or question that you might have if it's not something that you do often or familiar with. So actually, I thought it was a really great resource.
That is wonderful. And, anyone who's a parent out there knows that there are, just getting a quick answer to a question without having to go in for a visit is amazing, right? So on that same note, around new and different specialties that are perhaps just being introduced or incorporated in e-consult, Stan Frencher, MD, mentioned a good question that I had too. Is transgender a multi-specialty e-consult a category, or is it a single specialty? How do you see transgender services?
And so the same sort of thing, we have one of my colleagues, so in family medicine, and then I believe there's an internal medicine provider as well, who they also run a transgender clinic in one of our locations. And so again, because of, sometimes there's like access issues, or it takes a while, or maybe people are kind of comfortable with the hormone therapy and things like that, but maybe have further questions to people who do it more often. That's what transgender medicine is going to do. And so they've actually agreed, like they're all ready to come on. We're in the kind of template development phase for them. So it'll go to just these two providers. And it's mostly the hormone transition questions.
That's great. I'm sure it's a huge asset to primary care providers who are new to addressing these types of questions and services. Just a follow on to that last question was, there are other specialty categories served by having multiple specialists involved. And so maybe I don't know if you do specialist to specialist consults in these cases, or how do you do that?
So each specialty, like, I think if I'm understanding the question correctly, like each kind of set of conditions does go to one specific specialty. Some of them have multiple, like, for example, like resistant hypertension. I think both nephrology and cardiology offer that as an e-consult with different templates suited to what their needs were. But we did not limit to primary care providers. Most of the consults are primary care providers, but we didn't limit it. So really any specialist can also do a specialist to specialist e-consult.
That's great. Thank you, Dr. Nair. This is, as I saw your methodology so well described throughout your presentation, a question came up. Is this methodology shared? Is it something available to others who want to incorporate telehealth and e-consult? Your clinical transformation methodology?
Yeah, I mean, we had created at Rubicon MD a whole workshop, online program. There's the article. You can feel free to connect with us. It's open source, the article, and really what it is just a general roadmap. So in that case, yes, feel free to use it. Feel free to reach out to us. We're happy to answer questions. We just felt like it was so important because it can apply to any stage of implementation, and then also really any type of technology.
Thank you, Candy. And if you don't mind, I will share your email with those who are on our call today, and if they have follow-up questions, they can ask you. I wanted to note, I launched right into your presentation, and I skipped over your great experience that really shows in developing this comprehensive telehealth and e-consult program. And we've connected through Dr. Olawola, but Candy's experience with San Francisco, having worked at Rubicon MD, San Francisco Health Plan, it's great to have the payer, provider, and vendor experience woven in there, Candy, so thank you for sharing that today. And also, Dr. Nair, we really appreciate the fact that you can bring in these clinical examples, but also your deep passion for quality improvement, efficiency, patient safety that are really obviously key tenets to e-consult. So thank you again for your time today. And with that, if we have more questions, please share them via chat. But I'm going to hand off to Dr. Amin now. Thank you, Candy and Dr. Nair.
Thank you.
With that, Dr. Amin, I am making you co-host.
Well, actually, you know what? If this is, Libby, if you've actually got the slides on here, you can just continue. Do you want to just do that?
Sure, that's perfect. Thank you so much, Dr. Amin. I will introduce you briefly. We are so happy. We're going back to California. We had a great example from Ohio, back to our wonderful UC examples of e-consult. We have Dr. Alpesh Amin here today from University of Irvine, Thomas and Mary Cesario, Endowed Chair of the Department of Medicine, Professor of Medicine, Business, Public Health, Nursing Science, and Biomedical Engineering. Wow, Dr. Amin, that's a lot. Executive Director of the Hospitalist Program at UC Irvine. So thank you for joining us today, Dr. Amin. With that, I'll let you further introduce yourself if there's anything else you'd like to add, and I will advance as you tell me to. Go ahead.
Thank you, Libby. Well, it's a great pleasure to be here. I really appreciate the opportunity to share with you what we've done here at UC Irvine in terms of our e-consult program. Libby described the roles that I play, and really one of the things that doesn't get captured in these roles is I like doing innovation and practice redesign, and that's where I see this being a major force, if you like. So the background for us a few years ago when we were putting this together is, in Orange County, we have a really growing, and we have an aging and diverse population. It's the sixth largest county in America. We have no county hospital. We're the only academic medical center in Orange County, and so that gives you a little bit of a flavor of what we're a level 1 trauma and quaternary academic medical center. We also have we've been struggling with growth in a good way in terms of access and delivering care to our public, and we've wanted to do that. And access to specialty care has been a significant issue for us, and so e-consults became a potential solution here. Next. So you all know what e-consults is. I mean, this is just a reminder that, we started out actually by being for low complex appropriate patients. We partnered with our other UC campuses, and we were the only one that actually had an Allscripts. We were doing it on Allscripts while our other UC campuses were all on Epic. And so that created a little bit of a different workflow and different opportunity for us when we first started. And again, obviously it's PCP, the specialist, that you're requesting something and trying to get a response back. A simple case that we had on e-consults that I think illustrates the opportunities. You know, we had a patient that went up to the mountain skiing, fell down, injured himself, went to local urgent care, thought that it was just a little bit of a bruise. It was told that if you still have shortness of breath or difficulty breathing, go back down and see your doctor when you get back home. 2 days later, he shows up in our PCP's office. The PCP orders a chest x-ray. The chest x-ray, PCP is unsure, thinks it's maybe pneumothorax. He decides he's going to send a e-consult to the pulmonologist. Now, in our old system, it would have been, oh, let me send you to the emergency department, where you'd wait for 3, 4, 5, 6, 8 hours, you know, try to urgently get on the phone to see if they can go and see a pulmonologist in their clinic, which takes staff and other folks' time. The patient is inconvenienced through that entire process. This way, we just told the patient, go home. You know, the PCP sent an e-consult to the pulmonologist. The pulmonologist got an email reminder that he had an e-consult in his box, pulled up the x-ray, said that it was less than 10% pneumothorax, gave some instructions on breathing and so forth. The PCP got those instructions in an hour and called the patient at home and told him what to do, reassured the patient, and everybody was happy. So, you know, it's a wonderful system in the right population, the right patient group. Next. So what we did was we developed it at UCI by developing a custom solution. And we actually, I think, are one of the few places that actually use 2 different EMR platforms, or electronic health record platforms. We first started out with Allscripts, but then us being the only University of California you know, institution not on Epic, our Office of the President strongly encouraged that we shift over and be on Epic like the other UC campuses. So somewhere in the middle of our e-consult design, we actually shifted from Allscripts to Epic, and that was a challenge in and of itself for us. So I'll talk a little bit more about that next. So this was our plan, design, build, test, go live, and expansion, and we've done this across you know, 17 specialties, and we continue to slowly keep adding specialties, and I'll share with you those specialties. We actually, in order to make this kind of fair and appropriate, because people are maybe doing work, and in order to help facilitate timeliness, I was able to convince our system that we would either give them $50 or 0.7 work RVs. We started out by giving the department that was involved, both the PCP and the specialist, for every successful, and we defined it that it had to be a successful e-consult, because we didn't want the PCP to just order an e-consult that the specialist was going to turn around and say, I need to see the patient anyways. That's a waste of time. Also, we wanted the specialists to feel like they could complete it appropriately. So we gave them some cash value. When we switched over in our clinical integration to a work RVU driven metric, we gave people 0.7 work RVU credit, which aligns to some of the work that we've done with CMS to get this going. So, you know, my learning experiences that, you know, we had a good steering committee, strong leadership in this process. We defined workflows. I'm a big believer that you define the workflow and then you build the IT infrastructure to fit that workflow, as opposed to the opposite, because then you build culture and you can fit into some existing culture. We developed specific templates. We did a lot of education to get this launched off the ground. Next, and we staggered the specialties. We started with 3, then went to 4 or 5, 6 to 7. We staggered them upwards. Next. So the transition to Epic, as I said, was, you know, put us, you know, somewhere in that period. We had about a year where we had no e-consults happening, because we had success uplift during Allscripts, and then had another success uplift during Epic, but in the middle there. Now, the differences between the two systems are illustrated on this slide. In Allscripts, we designed a document-based e-consult workflow, whereas in Epic, it became an order-based e-consult workflow. In Allscripts, the request was routed to the specialty via a secure health message through a document-based workflow. In Epic, we actually was routed through specialty via distribution scheme and pools. In Allscripts, I was able to do a little bit more, where I was able to actually create notifications so that people knew that they had an e-consult in their inbox. That wasn't the easiest thing with Epic. And then specialists respond by creating a note in Allscripts, whereas they create what we call an encounter in Epic. So there's slight differences between the two models of build and launch and so forth. Next. So you'll see here that despite these differences between Allscripts and Epic, we were able to show that both EMR platforms can be user-friendly and develop user-friendly workflows and allow e-consults to continue to build and grow. And you can see with Allscripts in the second one in the first quarter and last quarter, and the latest Epic results, we had really good results of growth in all those areas. Next. These are the specialties that we have developed for e-consults. To date, we have completed close to 1,400, almost 1,500 e-consults, with about 650 of them being on the Allscripts platform, another 800 plus being on the Epic platform. We have a one-day turnaround, our average time. So if you think about what it takes for getting a referral into a specialist, our turnaround has been great, and we have an 80% success rate on e-consults that are resolved electronically. You also can see on the graphs below the amount of time that it's taking. Most of these are completed within a very short period of time. Our goal was always less than 3 days, and our average is, as I said, 1 business day. And then, and most of them, 80% or so, sorry, it's cut off a little bit at the bottom, but 80% is meeting success rate on e-consults. Next. These are some of the provider feedback we've gotten. The PCP, I love the service, lets me ask a very specific question of a specialist without making both the specialist and the patient wait for an in-person appointment. It addresses the patient's needs faster, and it allows the specialist more room in their schedule to see more complicated patients. I'm thrilled with the e-consult process thus far. The e-consults are highly efficient way to provide quick response to questions in primary care providers. It also gets rid of the concept of, to some degree, curbside. This improves communication and collaboration among physicians, and also access to specialty care, ultimately improves quality of medical care that patients receive. So that's some of the positive feedback. Next. So what were some of the lessons that we learned from the first phase of our e-consult program, which was the ambulatory, was that, and PCP, the specialist, is that it was the successful design implementation. We needed good clinical champions and technology partners, and our steering committee was a big help. Our experience with implementing the e-consult program on 2 different EHR systems, showed that it's more about the concept and the culture, and the systems help facilitate that. Providing modest incentive and reimbursement allowed for easy adoption and sustainability. Next. So the second phase of our program was, the fastest growing population in Orange County, which is the 6th largest county in America, is the Medi-Cal population. And there's about 700,000 or so to 1 million Medi-Cal patients in Orange County. And we have a big managed Medi-Cal population under Cal Optima. And one of the things and we actually at UCI own 2 family health centers, family health qualified centers. So, through the federal government grant processes and stuff. So the challenge we've had is we have UCI PCPs at FQHC sites, but many of the patients that go to those sites are Medi-Cal and managed Medi-Cal. And therefore, there's this big authorization process. The managed Medi-Cal does not want them to go see, does not easily allow them to go see specialists on, for secondary and some tertiary care. And so you end up having to send them into the community. So the PCP has to navigate, whereas, all right, since it's our PCP, they would rather be using UCI specialists. So that was a little bit, so we decided to put e-consults into our FQHC site. And we did it at 2 different FQHC sites, hoping that it would address challenges around economic resources, access to transportation, and insurance coverage issues. And we applied it, and we've actually seen really good outcomes. Over 99% of these patients, as I said, were low income, 200% below the federal poverty level, and nearly 85% of the patients have racial or ethnic minority. Next slide. And we've done almost 400 e-consults through FQHC. This now allows us to have our service the challenged patient population, get them access to our UCI specialists and allow for what our PCPs want that work in FQHCs to be able to access our specialists for their patients. And we've had, again, a 1 business day turnaround. 84% of these consults are resolved electronically, and 49% of these patients are in the managed Medi-Cal plan. So we view this as a huge success of giving back to the community. And we bear the cost of it right now, as a health system, until we can figure out some long-term sustainable, funding or contracting with CalOptima. Next. And then I won't read it here in the interest of time, but again, there is, very positive PCP feedback and specialty feedback to implementing this at our FQHC site. So this was kind of phase 2 of our program in e-consults. Next. And we were able to show these outcomes: improved access to specialty care, practice efficiency and care coordination, cost savings of e-consults, improved customer service and provider satisfaction. Next. Now, the third phase of our e-consult was really moving to specialty e-consults. And, here, we, more and more, you kind of have certain specialties that are taking on both not only their care, but also the primary care of patients, heart failure patients that are managed by a cardiologist that want to directly go to an endocrinologist for their diabetes, or a nephrologist managing dialysis patients that wants to access, cardiology or endocrine for their for e-consult. So we opened this up. Then the system was already built, so it was easy for us to open it up to specialty e-consults, where the physicians can go directly from specialty to specialty and bypass the primary care physician to get their questions answered. And it's all documented in the electronic medical record, so it works out nice. Next. And we've completed over 200 e-consults this way across 16 specialties, and 77% of these were resolved electronically. So same kind of outcome data, 1-day turnaround, plus minus 80% success rate, and there's slightly different specialties turn out to get more referrals from PCP versus specialist. And through all of this, one of the things that I've been really happy about is that the learning that inherently happens when we look at some of the e-consults that PCPs ask and specialists respond. The response is more thoughtful and clear, and for whatever reason, the specialists feel like they want to put more information in there that helps educate the PCP. So I think that's been a very positive thing. Next. And then our last phase 4 of the program, and there's continued evolution, is we actually have added e-consult program to inpatients. And here we've done it in 4 specialties, and we recently started cardiology, dermatology, endocrinology, and radiation oncology. And we're learning about this as we go. Radiation oncology, just started last week. And so we've designed workflows that use our current routine consult process. And we basically given people a choice that when you get the consult, we ask the primary team, whether that's a hospitalist or a surgeon or whoever, to request the e-consult. And then we and say that if it's a e-consult or an in-person consult, so they are starting to do that. And then these services can have a choice to either take it as an e-consult or convert it. And we're learning about different specialties, how they do it, and as we continue to move forward. But we've had a little bit of success on some of the initial numbers. If you look at the next slide. So in cardiology, there have been 26 e-consults that we've received on the inpatient side. 14 were successfully resolved. It's a low rate, 54%. So we're still learning about this in terms of, many of these require a procedure or so forth. So maybe 50% is the proper success rate. Maybe it's 70%. Maybe we need to go back to the hospitalists and surgeons and the primary inpatient service attendings and teach them how to request an appropriate consult, and also, so there's some reiterative work that needs to be done. Dermatology, on the other hand, we've had 15 where we've done 11 of them that have been resolved successfully. Endocrine, we've done 10, and 9 of them have been 90% success rate. And as I said, we just started radiation oncology and have several more that are going to be added to the pipeline. Next. So in summary, the e-consult program, and by the way, this inpatient e-consult will also hopefully help with kind of the downsides of curbsiding and medical legal risk, and also the upside of getting an answer pretty quickly as opposed to waiting for somebody to finish their clinic and come up and finish the consultation. So the enhanced access to and delivery of coordinated specialty care, we've seen increased efficiency, access to care costs being reduced, patient experience and satisfaction being better. And I don't think I have another slide, do I?
No, I think we're at the end.
Yes, and so I have a few minutes for questions. I saw one that came through, which centered around I don't see any surgery specialties except for gynecology, and that's a great question. In my system, the surgeons have been slow adopters, and it is on my list of things to do to get, and this may be one of these things where I'm going to end up, as I see other institutions getting them on, then us get talking to our surgeons here. But we at one point had a little bit of orthopedics on board, but there's been some turnover in some of the more natural surgical subspecialty areas to do this in, but they've been slow adopters at my institution, and we have more work to do in that area. You may have covered this already. I missed the first part. What's the proportion of e-referrals versus e-consults in terms of total number of requests for specialty expertise at UCI? So it's certainly more of it is e-referrals. I would say the proportion of e-consults on the ambulatory side probably are on the order of 10%, something like that. But it is slowly growing. We are also in the process of growing our primary care base, and so that will also help this grow as time goes on. And then we obviously have some specialties that actually, like gynecology and geriatrics, they actually serve as, they serve on both ends. They're kind of a PCP and their primary patients, just like nephrology or heart failure, dialysis or heart failure might be. And then they also serve as consultants also.
Thanks, Dr. Amin. There's a question that came in that this is really one of our key focus areas as part of this work group is primary care provider engagement and e-consults. And it seems like this is one of the big wins in your program, that you were able to get PCPs engaged both in inpatient, across the hospital setting, and in acutes. Did you use the same sort of incentive? I noticed that you used RVUs on both the primary care and the specialist side. Were there different incentives needed in different settings, or what did you do to get them?
We used the same one. We used the same when we were doing it on cash. We used $50. When we changed over to work RVUs, we did it on work RVU credit, and we give the same one. Now, at some point, some might say, well, what's the purpose of when PCPs request an in-person consult, there's not a need to do credit, if you like. But, I think for the small amount of resources that it takes, and it certainly makes them happier, it gets them into the mindset and frame set of that, I have multiple ways of going about doing it. It's the same thing like, I have multiple opportunities to request, and I should be thinking more globalistically about what's best for the patient and for the system in terms of consultation. I think also the same thing kind of applies on the inpatient side a little bit, where I've used the example of an iPhone with our specialists and say, look, we're developing tools to make your practice, redesign your practice to make it more optimal and better, with the hope that you're going to decrease, help us decrease length of stay and help us improve customer service and satisfaction. So, whether you use your iPhone as a computer or a camera or a phone, you've got multiple choices, and you're going to find people generally use things. The traditional route may be appropriate for complex, and certain types of appropriate patients, and the e-consults will be appropriate for other types of patients. We actually did publish a book on e-consults, which got endorsed by the AAMC, that actually takes cases across the UC system that is specialty by specialty, and it gives people an example of a question with the answer, another, so hopefully to help people kind of think about how to ask the appropriate question and then how to respond in a time-efficient manner.
We would love to share that title, and I'll reach out to you to get that so I can share it with our group. Thank you so much, Dr. Amin. I'll take any last question, but my last question for you is, what's your plan for scale? Are you gradually adding specialties? Is there?
Yeah, so I think the scale is, if you think of a three-dimensional model, horizontal, vertical, and whatever, I think at one level, my goal is to expand scope across the board. So we've gone from ambulatory to PCP to PCP, then FQHC, then specialty to specialty. So we're expanding scope, and then to inpatient. And so, I've even modeled out where we'll be doing ED. So it's to expand scope. The second one is to expand the number, the growth. So as we continue to bring on more PCPs, that should increase the volume of this, as well as encourage people who are already using it to use it more.
Thank you, Dr. Amin. That's very, very helpful. And I so appreciate your time today. It's great to engage with you and to have other examples of how this is working in academic settings and inpatient too. We look forward to talking to you on our future calls. And for sake of time, I have to wrap up here. We look forward to talking to you in the future. And I have two brief announcements as we wrap up today. Many of you have heard about our November meeting. It's happening November 16th. You will get an email invitation within the week to register for our November 16th meeting that's taking place in tandem with the Center for Connected Health Policy annual meeting. So we will be getting this out to you in the next couple of days. And one more announcement on that note. For those of you in California who would like to join for this week's Telehealth Policy Coalition meeting, I mentioned that's our annual meetings happening in tandem with the Telehealth Policy Coalition. Friday is the monthly meeting if you'd like to join that call also. Thank you everyone for your time today. And if you'd like to learn more about the eConsult Workgroup, if you're new to our group, you can visit econsulttoolkit.com. Thank you very much and have a great day.
Bye-bye.
Thank you, Libby.
Thanks.